Could next-generation anti-VEGF agents be dosed as infrequently as every 20 weeks without sacrificing efficacy? And even if there are data suggesting that finding, would anyone actually adopt it?
I'm Greg Notestein, he's Scott Chriswanis, and this is New Retina Radio from Retina Today and Bryn Mawr Communications. Dr. Philip Storey fills us in on TENAYA and LUCERNE data that explored in part how many patients could theoretically reach a 20-week dosing interval, and what baseline factors predicted whether patients were conducive to such a strategy.
And Professor Sobha Sivaprasad joins us to review findings from PULSAR. In particular, she focuses on data examining whether high-dose aflibercept could be used as long as every 24 weeks in wet AMD patients. Dual inhibition of VEGF and Ang2 might lead to longer treatment intervals for some patients with wet AMD, but are there pivotal data to show that these patients could be dosed as infrequently as every 20 weeks?
Dr. Philip Storey has some answers, which he presented at ARVO this year. Dr. Storey practices at Austin Retina Associates in Texas. Dr. Storey, thank you so much for joining us.
Thank you so much for having me. I really appreciate being on the show.
All right, so before we get into talking about Texas barbecue, let's first focus here on what you discussed at ARVO. You looked at TENAYA and LUCERNE data for this study. Which specific portions of the study did you explore?
I'm going to have to go with Texas barbecue first, and Terry Black's is the best.
There we go.
Diving into the data. So TENAYA and LUCERNE were, of course, the pivotal phase 3 clinical research studies looking at faricimab, the first bispecific molecule for the treatment of wet AMD, compared to aflibercept. Now, this study looked at faricimab dosed up to every 16 weeks after a loading dose, 4 monthly doses at every four weeks, and then extending up to 16 weeks. That compared it to aflibercept 2 milligrams dosed at 3 monthly doses, then to Q8 week, and it just stayed at Q8 week for the duration of the study. Patients in the faricimab arm were in fixed dosing, either Q12 or Q16 week, until week 60. At that time, they were then put in a treat and extend regimen up to 16 week, and that treat and extend was really based on visual acuity, anatomy, and hemorrhage. As long as they met predefined protocol specified criteria, we were able to extend them.
TENAYA and LUCERNE were huge studies. You were just looking at a smaller subset of patients in this study. Who exactly were you looking at, and what were you trying to find?
Yeah, so the purpose of this post hoc analysis was really to ask the question, could we have gone longer? Could we have extended patients past that 16-week interval? And the answer is yes. We were looking at the patients who already met dosing at 16 weeks. We used the same predefined clinical criteria to look at the possibility of extension. We applied it to this hypothetical cohort to say what % of patients could have gotten to 20 weeks.
We know that patients in the faricimab arms achieved non-inferior disease control compared to aflibercept, and that they did so with fewer injections. Remind us what else you and the research team observed in TENAYA and LUCERNE.
Yeah, absolutely. So almost 80% of patients were able to get all the way out to that Q12 week interval. Specifically, 78% of patients were on 12 weeks or greater. 63% of patients were able to get to that 16-week dosing. At 2 years, the faricimab group was non-inferior to the aflibercept group. Both groups did quite well, with a gain of between 6 and 7 letters compared to baseline, and losing about 140 microns of CST.
TENAYA and LUCERNE didn't have an option for a 20-week treatment interval. So how did you go about determining if patients could be dosed every 20 weeks?
Yeah, good question. So this was really looking at a predefined clinical criteria for extension. Throughout the actual study, we extended patients if there wasn't any fluid, if the fluid was stable, if it didn't increase by more than 50 microns, if vision was stable, if it didn't decrease by 5 letters or more, and if there wasn't any submacular hemorrhage. As long as those criteria were met, we were able to extend these patients out. So the goal of this study was really to say, hey, a lot of these patients were able to get to every 16 week. Could we have gone longer? So we applied that exact same predefined study criteria to the patients who'd already made it to 16 weeks to see if we hypothetically could have extended them all the way out to 20 weeks.
And exactly how many patients was that met that specific criteria?
Yeah, so 56% of patients in the study met criteria for extension to 20 weeks. Backing up, in the original study, 63% of patients actually met their criteria in the original study to be extended to 16 weeks. So that means the vast majority of patients who were able to get to 16 weeks likely could have been extended to that 20-week interval, with just a slight decrease from 63% down to 56%, meeting the hypothetical criteria for extension to 20 weeks.
The golden ticket is knowing which patients might be most likely to reach a 20-week interval. What characteristics were linked with eligibility for Q20-week treatment?
Absolutely. Great question. So we did a subgroup analysis of these patients who met criteria of extending to 20 weeks. And we said, what was different about those patients than the patients who failed their criteria, who we couldn't have gotten out to the 20-week interval? And patients who could be extended had less fluid, lower CST, lower PED thickness, and they had PEDs that were only fibrovascular in nature, i.e. there weren't any serous PEDs or fewer serous PEDs, and there was less intraretinal fluid. So basically less fluid, lower PED height, fewer serous PEDs, more likely to be extended to that 20-week interval.
All right, Dr. Storey, 20 weeks is a long time, and I can see some of your colleagues not exactly being comfortable with going that long without seeing a patient with wet AMD in their clinic, especially if they're a patient they've been seeing on a routine basis for a long time. These data are compelling, and I'm curious if they've changed the way you've practiced in your clinic and what you think your colleagues might do with information like this.
Yeah, great question, Scott. Historically, we weren't comfortable extending by 4 weeks either. Historically, we've only really been comfortable extending by 2 weeks. But now we have very strong data that says, hey, we can go longer between intervals, both extending and overall absolute numbers. And the data is compelling. I don't hold it against those retina specialists who are a little bit leery. All of us are scared of seeing recurrent hemorrhage or the possibility of losing vision, but the data is strong. And as we get more comfortable with this molecule, with these second generation anti-VEGF agents, I think all of us will be a lot more comfortable extending our patients longer than we ever have before. And the longer we can go between shots, the less the burden it is for our patients. And I think everybody wins.
And are these patients that are being extended to 20 weeks, say, in the real world, are they still coming in periodically for observational exams and just not receiving an injection, or are they truly coming in every 20 weeks?
I'm comfortable just having them come in every 20 weeks, as long as we've been able to extend to that appropriately. I certainly wouldn't go from 8-week dosing all the way to 20-week dosing, but if we've extended over time and we haven't seen any recurrent fluid or hemorrhage, then yeah, if I get a patient all the way out to 20 weeks, they just come see me once every 20 weeks. Of course, if they have any changes, distortion, lost vision, by all means, I want them to come in earlier, and I always emphasize that. But otherwise, yes, I'm comfortable with going 20 weeks between visits and injections.
All right. Well, Dr. Storey, thanks for swinging by New Retina Radio and joining us today.
Thank you so much for having me. Have a great day, guys.
The data on high-dose aflibercept for wet AMD are in. High-dose aflibercept is safe and effective and is non-inferior to 2 mg aflibercept despite less frequent dosing. We learned all of this from the PULSAR study.
But with every answer comes new questions. Today's questions: how well did patients on high-dose aflibercept do at 96 weeks? And are there data to support treatment intervals as long as 24 weeks?
Professor Sobha Sivaprasad is here to help us find out. Professor Sivaprasad is a researcher and clinician at the Moorfields Eye Hospital. Professor, welcome to New Retina Radio.
Hello, I am delighted to be here today as we now have yet another treatment option for our patients.
Most of our audience is familiar with PULSAR, the study that assessed the safety and efficacy of high-dose aflibercept for wet AMD. For the sake of a refresher, can you give us a very brief description of the study and its findings?
In PULSAR, patients with wet AMD were randomly assigned to 2 milligram aflibercept or 8 milligram aflibercept given every 12 weeks or 8 milligram aflibercept given every 16 weeks after 3 loading injections. Patients could have their interval shortened in the high-dose groups if pre-specified criteria were met. Starting at week 52, patients could have their interval extended if a different set of pre-specified criteria were met. At both endpoints, that is week 48 and 96, the best-corrected visual acuity gains from baseline in the high-dose aflibercept groups were non-inferior to the 2 milligram aflibercept arm. Same can be said about the central retinal thickness. There were fewer mean injections given in the high-dose arms. That is, 13 injections were given in the 2 milligram arm versus 10 injections in the 8 milligram Q12 arm versus 8 injections in the 8 milligram Q16 arm. There were no significant safety signals.
Excellent. So let's first talk about interval shortening, which you and your colleagues studied. How many patients met the criteria for shortening their interval at week 48?
We did an exploratory analysis of the PULSAR trial, and among the 2 milligram group, 15% of patients would have met the criteria for an interval of 4 weeks. Among the high dose groups, only 6% of patients would have needed 4-weekly dosing. At week 96, 22% of the 2 milligram patients and 11% of the high dose patients would have needed 4-week dosing.
Let's now talk about interval extensions. How many patients met the criteria for a longer interval?
For this, both of the high dose aflibercept arms were examined. At the last assigned dose at week 96, 87% of patients in the 12-week arm were still on dosing of at least 12 weeks. 16% were eligible for 20-week dosing, and 25% were eligible for 24-week dosing. 78% of patients in the 16-week arm were still on dosing of at least 16 weeks, and 22% were eligible for 20-week dosing, and 31% were eligible for 24-week dosing.
So I'm thinking about how all of this applies in a real-world setting. A 20-week dosing regimen seems long, given what most retina specialists typically assign, and a 24-week regimen right now seems almost unimaginable. So walk me through how this would fit into the real world. Are providers going to see patients every 20 or 24 weeks if they're on high-dose aflibercept? Are some patients going to come into the clinic only for examination but not receive an injection? And if that's the case, is that really reducing treatment burden if patients still have to take the time to come in?
Now, the clinical trials are designed to test the durability of a drug. And these results have proven that the duration of the drug can go up to 24 weeks. But in the real world, we all know that a population will reactivate earlier. And at present, we don't know who they are. So I would recommend monitoring patients with OCT every 12 to 16 weeks. And this can be done in primary care or at the local optometrist or in the eye clinics themselves. Patients then need to be seen in the injection clinics only if the disease reactivates. In this way, I hope that the capacity issues of these services will improve with time.
That certainly makes sense. Professor Sobha Sivaprasad, thanks for joining us on New Retina Radio, and congratulations on a successful ARVO lecture.
Thank you.
That concludes our first episode of coverage of the ARVO 2024 meeting that happened recently in Seattle.
We have one more episode left, so be sure to subscribe to the podcast so that it shows up in your feed.